So just by way of introduction, I am trained in internal medicine, and then I trained in medical oncology. Sexual health came as an afterthought during fellowship. And it's only because I worked with some specialists in this area, and until I did, I was probably like most of your oncologists. I didn't talk about it. Most oncologists do not bring it up at all. We're too busy talking about side effects. How are you doing? Do I have to worry about your cancer coming back? Okay, I'll see you in 3 months. And then we send you out your way. We talk about neuropathy and fatigue. But most of us in medical oncology never got the opportunity to learn just how important this is to you. So I was very fortunate about it, and I got trained on sexual health in normal patient populations, and I translated that into the sexual health clinic. So these are my objectives for you guys, and I'm giving you the same presentation I give to my colleagues. So I want you to hear what I actually say to other professionals, because I don't think there should be a difference in what you hear. So I want you to be aware that if you are having issues in sexual life and in intimacy, you are absolutely not alone. Probably everybody in this room is affected somehow in their sex lives. There is a relationship between intimacy and intercourse that differs between men and women. We are clearly from Mars and Venus, and we need to get on the same planet. And then I want you to understand what providers can do for you if this is an issue for you. Regardless of the cancer type, the majority of patients, when asked, say, cancer and treatment has affected me. For women with breast cancer, it's almost universal. Same thing with women with gynecologic cancers, but across the board, over half of our patients are being affected by this. And it's a real long-term issue. So this is the Livestrong survey, now 7 years old, predominantly white, majority female, majority educated. Sexual function and satisfaction was problematic in over half. In almost 30%, it was a very big problem. And it was linked to issues beyond just the bedroom. Sadness and depression, personal appearance, and over 60% of patients said it was affecting their personal relationships. This is a huge issue. You are absolutely not alone. It's important to know when I stand here and talk about sex and intimacy, I am absolutely not talking about intercourse. For women as well as for men, sexual health encompasses intimacy, sensuality, body image, arousal, desire, climax, and satisfaction. All right? So as I go forward, remember, we are talking about sexual health. We are not talking about an act. True or false? After a diagnosis of cancer, sexual health is impacted in men and women in a very similar way. You can actually say true or false. False. Absolutely false. This is men. We're on and off switches. Either it's working and we're ready, or it's off and we'd rather watch TV. This is women. All right? And just like a computer board, when it's working, it's fine. But when it's not working, if it's not turning on, or if it's turning on, it's sputtering, it's really confusing. For you and for your partner. This is why. So in this model, which is from Rosemary Basson, sexual health in women is a propagating circle. And what we think is it's a biological and a psychosocial connection. Women want intimacy. At some point in their lives, they want something else. That intimacy makes them aware that certain parts of their body, when touched, leads to arousal. And it's that arousal that makes you want something more, desire. And when desire is satisfied, that circle propagates. What's missing in this circle? Intercourse. Okay? Women don't need intercourse. Doesn't mean that you don't enjoy it. Doesn't mean you don't want it. But it is a means that links desire and satisfaction. All right? So desire is not contingent upon an act. Okay? This is why I hear from my own patients, if he just did the dishes, I would feel really good. Okay? This is not how men work. The other thing, for breast cancer-specific patients, we now know that there's something called breast-specific sensuality, that the breasts are really important for sexual health. This is work from Jennifer Gossett-Brown. So she went back and looked at the patients she treated, and she asked them, before surgery, how important was chest play to your sexual life? Across the board, over 80% of women said, my chest is really important. Chest play after surgery. How about now? How about after your surgery? It fell by almost 10%. And in patients who had a mastectomy without reconstruction, it was a huger loss. And what was interesting, it was tied to satisfaction with the surgical outcome. So now she took the patients who had a lumpectomy and compared them to women who had a reconstruction. So this is asking whether or not the breast remained a part of sensual life for a woman. And then the figure here that I want you to know is that lumpectomy, mastectomy with reconstruction, 40% don't view their breasts or their chest wall as a part of sensuality. In fact, 28% who had a lumpectomy, 50% who had reconstruction after mastectomy felt nothing when their breast and chest wall was touched. Men are not aware of that. Your partners are not aware of that. We need to teach them that. Okay? What is even more concerning is that 20% lumpectomy or mastectomy with reconstruction, when you touched her there, it hurt. That is actually something that was never reported in the literature, but it's a real life phenomenon that I was just recently made aware of 3 years ago. So why is it important just to talk about this? Not just to say, oh yeah, it's real, it's not in your mind. It's because we can actually do something about this. Most of what I'm going to talk about next are related to women, and I apologize for that because I know we do have some male breast cancer survivors in the room. When I talk to women, though, about sexual health, I break it up into two very different spheres. I want to talk about vaginal health, just like I would talk to you about moisturizing your skin if you're on chemotherapy. There are ways to take care of the vagina to make it healthier. Nothing to do with sex. So for vaginal health, I talk about moisturizers. And I talk about the different kinds of moisturizers that are available. There's a polycarbophilic-based moisturizer. There's even something called parabens-free. Parabens is a chemical that in the laboratory has some estrogenic properties. If it worries you, there is a formulation that is parabens-free. I tell women to use this 5 times a week and then 1 hour before intercourse. The goal is to reach a more normal pH internally so that the normal flora that we have in our vaginas, well, not my vagina, your vaginas, is normalized, reduces the risk of an infection, and also provides more moisture. All right? If you didn't want to use a chemical, you could use natural oils, externally on the vulva, you can use vitamin E. And I'm not talking about the tablets. I'm talking about the oil-filled capsules that they sell in any nutritional store. Snip off the cap, put it on your finger or an applicator, and apply it on the mucosa of the vagina. 5 times a week, an hour before intercourse. There is something now available called vaginal laser therapy. Yes, lasers in the vagina. All right, so this is the same technique that women used to use on their face to smooth out wrinkles. There's a 3-procedure vaginal laser, all right, that has been shown to be effective in women who have reached menopause, who have thinning and dryness of their vulva and vagina. And 95% show that it worked. The data in women with breast cancer is actually much less concrete, but there is one report out of Italy, 50 women who had pain with penetration, and the most important points are here are the outcomes. They had significant improvement in painful intercourse after vaginal laser therapy. They had significant improvement in thinning and dryness, and it persisted almost a year later. All right? So this procedure is available. It is usually not covered by insurance, and it costs about $4,000. Next. Okay, so I'm sure I'm going to get plenty of questions about that. But so the other thing to know about, though, for women who are having issues in their vaginal vault is there a role for estrogen? The answer is yes. Okay? Vaginal estrogen appears to be safe even if you have a hormone-positive breast cancer. Right? The data suggests there's no association with a risk of recurrence, risk of progression, or death if you use vaginal estrogen. This is the American College of Obstetrics and Gynecology opinion, which is essentially what I just stated to you. You can use vaginal estrogen. It is preferred to use it as a second-line treatment if you don't get a benefit from the moisturizers and non-hormonal approaches. But I am very comfortable providing vaginal estrogen to women after cancer, no matter what kind. There's a drug called prasterone that just reached market. This is dehydroepiandrosterone, DHEA. All right? It was based on a study of 200 women, and it showed in this very complicated figure that compared to placebo, women had better outcomes in terms of sex, comfort, and atrophy or thinning. There was a study of the same drug in women after breast cancer and gynecologic cancers, and it showed essentially an improvement in sexual function if you use it vaginally, the side effects, voice change and headache, but more importantly, there seemed to be no systemic risk that you're absorbing estrogen. What about oral estrogen therapy? It is contraindicated. So we do not provide pills to women, particularly after breast cancer. However, my population of women with ovarian cancer, cervical cancer, or uterine cancer, I give them estrogen. Hormone-positive breast cancer, the reason we don't is this study called HABITS. HABITS enrolled women with early-stage breast cancer and randomly assigned them to hormonal preparations or to placebo. And essentially, hormone therapy was associated with more local recurrences. But more importantly, though, just look at this. Nobody died. So the bottom line from HABITS is that if I were to give you hormone therapy, there's at least a 2-fold increased risk of a recurrence. The 5-year incidence was 22% on hormone therapy versus less than 10% in placebo, but there was an unknown impact on mortality. So for now, we don't generally provide oral therapy because of this trial. You need to know that vaginal estrogen, there are different types. My preference is to use the estrogen tablets because the dose is so much smaller. And women often will say it's also less inconvenient because it's a tablet that they place into their vagina at night. It's not messy. There's a drug called ospemifene. It's vaginal tamoxifen. I don't know if you heard about it. It was approved for women who are postmenopausal, who have pain with intercourse and thinning. It is not indicated in women with breast cancer, not because of a safety issue. I actually don't think it's a safety issue. I just don't know if it's going to work. You have to use it every day. There's also estriol, which is a very, very low dose of estrogen, not approved in the US, but it's very nice data suggesting that even a very small dose can be effective in women. So now we talked about vaginal health. We're going to talk about sexual health now. How do we go about improving comfort? You need a lubricant. There are two types of lubricants, water-based and silicone-based. There is no difference in which one women prefer. The only preference that came out in the studies was for women who were having anal intercourse. They preferred the water-based lubricants. The difference for you to know about with water and silicone-based lubricants are silicone will stain your sheets. Water-based lubricants will not. If you don't want to use a lubricant, you can use olive oil. There is actually a study. All right, so this is the Overcome study. It was a small study. It was part of a three-pronged approach to help women have better sex. They used olive oil during intercourse. And look here at the bottom line, 73% of women really like the olive oil. So if you're worried about your kids finding something weird in your bedroom, just keep some olive oil in there. It's easier to make a salad. Right? Okay. So for women who are having issues just with initial penetration, so this is the woman who comes in to see me and says, I just don't even want to go there. Every time he comes near me and he just tries, it's like lancing into me. He just needs to stop. There is a very quick treatment for that. That is called vestibular tenderness. The muscle of the vagina in the initial entry point is where it's tender. There was a study that used lidocaine, 4%, very dilute, lidocaine applied with a cotton swab that was placed on the vestibule for 3 minutes before penetration. 17 of 20 women who did it were able to have comfortable intercourse afterwards. All right? So I prescribe a lot of lidocaine to women in my practice. You can tell the partners, I tell my colleagues to tell their partners, there's no risk that men will have anesthesia on their penis. Okay? It's a huge issue. All right. However, for women who have pain during thrusts, during penetrative thrust, that's called vaginismus. It's your smooth muscle in the vaginal walls are constricting because they don't want to have pain. So the rule is something for you to know. If you lay there willing your vagina to relax, or your partner is saying, just relax, it's gonna be fine. Or you're telling yourself, if I could just relax, it's gonna be fine. Your vagina will not listen to you. She will not listen. She will try everything under her power to get it out. Okay? So the treatment for that is to connect the mind and the body again. And this is how I explain it to patients when I give them dilators. You're putting the power of penetration in your hands. You're inserting a dilator to the point of pain and no further. You're teaching your vagina that you're going to protect her. Okay? And you're going to teach her that it doesn't have to hurt. It takes a long time to go from a small to a large. And I tell the partners it's not supposed to be anatomically correct. Okay? What about the other aspects of sex? Desire is a huge issue. Everything could work, right? Everything could work. You can, you're in the bedroom, it's great. You're getting excited, aroused, you have desire, it's satisfying. After it's all over, though, you're like, if I never did that again, it's fine. It's fine. I could watch TV, we could have sex, whatever, it's fine. That's a desire problem. Okay? And for women who have hypoactive sexual desire disorder, there's a drug called flibanserin that's on the market. It works centrally to increase excitatory signals and depress repressive signals. You have to take it every day, which is why it's not Viagra. Okay? And there's a strong risk of low blood pressures and passing out, particularly if you drink. So what the FDA has made us do is I have to get trained to give flibanserin, your pharmacist has to get trained to give flibanserin, and you need to sign a contract with me that says you will not drink while you take this drug. Ask me how many times I've prescribed flibanserin. None. All right? But the reason it got approved was a very interesting analysis called the responder analysis. So in these trials, half of the women got flibanserin and half of the women got placebo. They looked at the patients who actually had an improvement, and what they were able to show is that using some standardized questionnaires, there was a huge improvement on flibanserin compared to placebo. Almost double the response to placebo. But look at this, really interestingly. People taking placebo still had a benefit. 30 to 40% of women, just do something, it'll work. And it won't cause low blood pressure and force you to pass out. What about Cialis? What about Viagra? Does those work in women? The answer is probably not. Okay. At least the small studies that were done showed that even compared to placebo, there was no benefits. The only time I use it is if you're taking an antidepressant and you're having issues with sexual health. Sometimes it works in that one situation. What about testosterone? We know testosterone works in women who don't have cancer, who have desire problems, or had a reduction in their sexual drive after a hysterectomy, but not for cancer. What about for women with cancer? Are the side effects of testosterone worth the benefits of testosterone? And the answer is no. So there was a randomized trial of testosterone versus placebo in women after cancer. It was very complicated. It didn't work. So compared to placebo, there was no benefit to testosterone. So I actually do not prescribe testosterone in women after cancer. What's curious is testosterone may still have a life for women after breast cancer to help reduce the symptoms of menopause. So that's how we're actually evaluating this drug. So what do I tell your doctors about the role in your sex lives? And this is for men and for women. We, in medicine, should never accept the following reasons why we're not bringing it up to you. And you should say, are you not talking to me about my sex life because of any of these reasons? Because if you're not, you're being unfair to me. We're too busy in medicine. You're single, so clearly you're not interested. You're too old. Clearly, that's past. You have metastatic disease. Why on earth do you want to have sex when you should be concentrated on living? You survived cancer. You're so lucky. Nothing else matters. And really, the main reason is I don't want to open Pandora's box. I don't want to go there. I don't want to hear what you're going to tell me. So these are some of the reasons why we don't. But your clinicians need to normalize sex for you, just like we talk about diarrhea, just like we talk about neuropathy. It is not that far of a stretch just to ask you a question. Sometimes cancer influences or depresses sexual activity. I'm wondering if that happens for you. I go around the country trying to tell my colleagues to ask. And there's an approach to it, but everything that I told you today is what I cover in a consult. Most women who see me feel that no one else is going through that. It is an incredibly lonely experience to see that your sex lives are different. But you're not alone, and I can help explain why the computer isn't working. What you all need to know is that time actually is a cure. That with time, things do get better, even if you have early disease or metastatic disease. Time is a really great medication. Some of the things I talk about during that time is trying to get men and women and their partners to be on the same page. What are you looking for? Let's try to work on some things together. Most of the time it's around intimacy. But I don't say, go home and work on intimacy. Because men hear that, they want to have sex. Right? So I tell my women and their husbands, or the men who see me and their wives, go home and play. Men seem to understand the concept of play, as do women, because they like to play in general. Okay? So it's the whole point of reintroducing sexual activities, not solely focused on penetration. And we know it can provide value, that couples who cannot have intercourse for whatever reason adapt, that things that are non-penetrative can be highly satisfying, but that we as physicians, we're all about the penetration experience. Our patients are telling us, even if that's not part of my sex life now, I still want something. And we can teach partners to appreciate that too. So in conclusion, we need to communicate with you better. You need to be proactive about this part of your lives as well. So if your doctor isn't asking, don't sit there. If it's important to you, we should hear about it. There is consultations available. There are compromises you can make in a relationship if intercourse is a problem. Seek clarity between what you want, what you need, what you wish for, and see what your partner does. Is it the same? Because after cancer, this is my concluding slide, everyone deserves a sex life. The young adult, the older patient, patients in relationships, patients without a partner, lesbian, gay, bisexual, transgender, and queer patients, patients with advanced or metastatic disease, and your oncologist. Thank you very much.